entirely up to you. I much prefer if you do it because you know where you are in the thing.
Yeah, that's fine.
Excellent. So we're now recording. So welcome everybody to the first inaugural DRACHMA meeting. And essentially we've all got an interest in advancing drones and their use for community healthcare and medicines access. And we've got a range of expert researchers, expert users and expert developers. Where did this come from? A few months ago, I was part of a collaborative team where we tried to apply for a grant to set this up a little bit more officially, and sadly we were refused. We were rejected from the EPSRC, but many of the people involved thought it was a cracking idea, so we've carried on. So essentially, it's a space for academics like me that have got a few groovy good ideas to support you guys in the drone community. You guys in the drone community with some needs, and also those that are developing solutions to sort of come together in a space where ideas can be exchanged, and then hopefully we can take hold of this kind of area of technology and start to apply a little bit of pressure to some of the regulators, some of the funders, and if we come together as a big group, possibly then we could have a bit more leverage in things like grants and permissions and that kind of thing. So my initial stab with Patrick, is Patrick Courtney here? He's my collaborator in this. Hi, Patrick.
Yeah.
So we're both academics at King's College London. Patrick's got more of a robotic background. What am I? I'm very interested in medicine stability and formulation, and this is why I've arrived at this particular area. So the kind of format that Patrick and I sort of came up with as a first bash every first Thursday of the month, to have an hour's fairly concentrated and focused meeting, but with the idea that would open it up and get conversations going and get discussions going. It's online, as we've seen, and as we said, really it's to create new collaborations to develop this particular area. So we've got two fantastic speakers. We've got Deirdre from the Oxford County Council, kind of representing a really good user case, and we've got Hammad from Apian, who's really thrusting in the area of sort of getting permissions and getting regular drone deliveries off the ground. And that's an awful pun, sorry about that. So what have we got? There's our plan, our agenda, and just a few little comments here. You can see, and if I come over here and show you, you can see we've got, if you're unfamiliar with Teams, there's a little chat area here, and you can put messages up there. Because of restrictions, I can't email a huge great list to everybody. So the workaround is, if you want to expose yourself, leave your contact details, get some conversations going, put those in the chat. As we're going along, any questions that come up, I would encourage you to write them in the chat box as well. It's usually feast or famine. I either get in these types of meetings 1 or 2 questions or hundreds of questions. If there are many, we can then look at the voting. So if you quite like a question, give it an emoji, give it a thumbs up, and then I'll try and give prominence to those that have had good reactions. We are recording it at the moment, and I will attempt to share that at the end. It's being recorded as a Microsoft stream. Once it comes through, I will attach it to an email and send it to everybody. But then at the end, we'll have a discussion about how we want to take this forward. And so without further ado, can I invite Deirdre to take charge of the screen?
Take charge of the screen with pleasure. I hope I can. There we are. Hopefully this works and you'll be able to see my presentation. So hi, everybody. Well, this is loading up, hopefully. Right. Are you able to see this as full screen, Paul, or does it just go through like this?
No, I can see it as a full screen here.
You see it as full screen. Okay, I don't. Brilliant. So first of all, thanks very much for inviting us to speak. I think this is a brilliant idea. It's a great community. We're involved in another initiative like this in the EU that my colleague George Fortinis will talk about later. And it's really fantastic networking opportunity, and it's good to be with like-minded people. And I'm also pleased to see that there's lots of NHS colleagues on this call as well. So my disclaimer is that I am a health and care innovation lead in local government. I'm not a clinician. I do a lot of work within the health system with the NHS. I work within a team, a dedicated innovation team in Oxfordshire County Council. I think we're the biggest innovation team in local government in the UK. We were one of the first. And what we're going to talk about, and it's very much, this conversation is more, from my perspective, it's a boots on the ground social acceptance take on UAVs. So I'll go to the second slide. Are you seeing my second slide properly? Is it green?
Absolutely green, yeah.
Perfect, okay, fine, great. So just talking a little bit about the innovation team at Oxfordshire County Council, and I won't bore you to death and read out the slide, but we are a large team. There's 27 of us. 24 of us are externally funded. And our team is growing all the time. And what that presents us with is the opportunity, because we work in so many different areas, to capitalize on emerging themes, on emerging technologies and innovation sectors. And that's been really, really true in the drone space. In that we have a dedicated future mobility team, obviously a health and care team as well, and we were able to come together and have a cross-sector conversation with all the right skills, all the right contacts, technology partners, academia, everything else, to be able to get a project off the ground. It does give us a lot of freedom as well, because as I've said, we work in local government, but of the 27 of us, 24 of us are absolutely externally funded. And just to give you an idea of our reach, and the only details I have right now are for the financial year 18-19, but in that year we brought in excess of £6 million of innovation funding into our local authority, and 50 million reach across the region. So it's significant, and there's a lot of freedom for us to drive forward those innovative approaches that kind of siloed working within establishments like the NHS or like local government don't necessarily allow, because everybody's so busy getting on with the job. I'll introduce my colleague, George Fortinas, to talk about how we've been able to capitalize and exploit those partnerships that we have in the drone space. And George is our UAV analyst at the iHub.
Hello, everyone. So we're at a stage now where organizations like the iHub are so ahead of the curve, because we have cultivated and nurtured our relationships, that we can capitalize whenever the opportunity arises. From the inception of the iHub, we were looking at present-day problems and focusing on future solutions. Because of this, we are the first local authority that has played such a massive role in the connected autonomous mobility sector, with George Economides and Ruth Anderson's work on both ODD and the PAS. Now it's time to move forward with drone technology innovation. We do feel that COVID-19, with its own unique set of problems we are tasked with solving, has opened a world of possibilities and broken down barriers, and has also cut through a lot of bureaucracy. In essence, the time is now, with the goal of bringing innovation into reality. If you can put on the next slide, where I'm going to show some of the projects that we're currently working on. So the first project I'm going to talk about is Harmony. The final result for Harmony will be a set of recommendations for regional authorities to plan their short, medium, and long-term strategies and update the sustainable urban mobility plans. These guidelines will close the gap between understanding and planning the mobility of the future, which will also include drones. On the second one is the European Commission's EIP Urban Air Mobility. This is building upon the Harmony project, where UAV trials will be conducted with Airbus and Griff Aviation. OCC is part of the European Innovation Partnership Urban Air Mobility Group, where we will be leading primarily on urban planning and air mobility. On Shimano, OCC together, along with the consortium partners, which consist of aviation technology, communications, and data specialists, will provide the next generation navigational capabilities that will permit UAVs to resiliently operate beyond visual line of sight in very high risk, low level flight environments. And Project Dromedos, which I will be speaking about in more detail later on in the presentation.
Thank you, George. Okay, so on to the wise words of Albert Einstein, and it makes me think. You know, COVID-19. We've all had a challenging, difficult year. But what I think about is my last face-to-face meeting that I had with NHS colleagues, and that was in February last year. I didn't know it was going to be the last face-to-face meeting that I was going to have for a year, but we knew what was coming, and I don't think we knew the extent of it, but we knew. And the comment that I was having with this colleague, who's quite a, somebody I work with closely in the NHS, was, wow, it's going to be kind of buckle up, there's a storm coming. But we also knew that there was going to be incredible opportunities for transformation and innovation out of necessity. And I found that for me, working in the technology space, in the innovation space, has been really, really true. So it's the one good thing. And I don't know if NHS colleagues that are on the call would agree with that, but people have been kind of prepared both in local government and in the NHS to kind of cut through bureaucracy and just do things differently because we've had to. And that's something that I hope that we can maintain that momentum. Certainly, once you get outside of the box, you can never think inside of the box again. So that's, I guess, it's a benefit to what we've been through in the last year. So leading on from that, thinking about COVID-19 as the art of the possible. The timing is now for new technology. I think that, as I've just said, and I would include within that not just the NHS. I talk about health and social care. There's been a real ability to mobilize and use new technology, and I'm thinking about. And we work in really high risk regulated environments, so it's understandable that in normal times people want to be risk averse. But I think we've had to do things out of necessity, and telemedicine is a really, really good example of that. And I don't think we'll ever go back to straight up face-to-face consultations the way that we used to. But I can remember before the pandemic kind of putting together a pilot that involved telemedicine in care homes, strangely enough, and the amount of kind of planning and business case and kind of risk appraisal and buying the right kit and doing this, that, and the next thing. And then when the pandemic hit, literally people were doing those telehealth consultations, on iPhones because they had to, because of infection control. So I think that also something that I would say, and I on the slide here, it says, when we talk about social acceptance, I think when we talk about social acceptance with drone technology, people understand that to mean citizens. I think, there's quite a bit of evidence out there that citizens and the general public and people on the ground are not necessarily averse to using drone technology or scared of using drones technology when it's for public good. I think that for me, when I think about social acceptance, I'm more thinking about social acceptance in terms of system decision makers, because that is where the rubber hits the road. If you have an enthusiastic leader, a visionary leader in health and social care that's prepared to trial new stuff, you're gonna get that adoption and uptake. And the way that we've been able to do that in Oxfordshire has been, COVID-19 has presented those possibilities, and we've been able to do that through, I always believe, I'm a huge believer in seeing is believing, so I believe in really lean learning approaches, piloting something very small scale, being able to show systems what is possible and then scaling up. So that's our plan. And I'll let George talk to you about our current project in Oxfordshire. And I know that I hope that our partners from Unmanned Life are on this call. If so, hi.
So with Project DRACHMA, we propose to assist the healthcare sector as a whole by deploying autonomous delivery of medical supplies to care homes. Together with Unmanned Life, who have been amazing to work with, we will collaborate to deploy autonomous UAVs that deliver medical supplies, including acute medicine and some lightweight PPE, from pharmacies securely and timely to the care homes. With this trial, we are looking at reducing the impact to pharmaceutical logistics for this and any other pandemic that may come in the future, if hopefully not. By deploying autonomous drone delivery, we will ensure a quick turnaround time for medical supplies, reduce the contamination of couriers, and increase the number of supplies delivered, and all that at a lower cost, which will ultimately save more lives.
Brilliant. Thanks, George. So thinking about future applications, and I by no means have a crystal ball, but this is probably my wish list. And I think it's a realistic wish list, building on what we're able to pilot at the moment, as George has just talked about with our project DRACHMA, where we're doing contactless delivery of acute meds into a care home. I would think that the next step and something to think about is expansion of that into vulnerable people in the community. There's also great potential for prescription deliveries, both to vulnerable populations, but also to rural populations using drones. And something that thinking about what the pressure is that's coming down the line, and this is a conversation that I have with a lot of colleagues. I know that COVID has been really, really difficult, and we've got to get through COVID and get back to normal if we ever do. But when we do get back to normal, there's an incredible backlog of people that have not been able to be seen by the NHS over the last year. So, cancer screenings, so on and so forth. How can we make those more accessible for people? And something that I've been thinking about, you can probably tell from my accent that I spent a lot of time across the pond. So there is a trial going on at the moment, both in the United States and in Canada, around early detection of colon cancer. So it's a screening pilot. And basically it's a postal screening pilot. It's allowing people to do an FIT. So for people who don't know what that is, it's fecal immunochemical test, which is a fancy way of saying taking a stool sample, basically. Patients are posted out instructions for self-administering that test, taking their own stool sample and returning the test to a lab by post. And then they get the results later on an online patient portal. So this sounds great. This is fantastic. It's brilliant for the patient. What's great about it? Early screening, getting a hold of more people, catching them early, and they know that 5 to 6% of people have a positive test and will then book a follow-up colonoscopy. So it's something that we absolutely should be doing. From March to May in the US last year, cancer screenings fell by 90%. I don't have the stats in the UK, but it's probably, I don't know how far off it is, but it'll be something similar. So this is a brilliant concept. So what could possibly go wrong? What could possibly go wrong is that we're depending upon the Postal Service, and I'm not trying to do them any discredit. But when you're trying to engage people into clinical interventions and kind of strengths-based interventions where they are doing their self-screening, it's got to be dependable and reliable. You don't want to have to give it FIT and go ahead and do it twice. So I think there's huge potential around screening. And a real-life scenario that we've worked on. We did do some data analysis for an NHS partner that we work with, thinking about bloods transport between a reception site and a specialist lab. And the specialist lab, if you think about bloods that need to be screened for people for operation purposes or whatever, it's time sensitive cargo. And this partner were doing hourly runs, sometimes more ad hoc. And they were, so, at as you would imagine, an eye-watering cost. They were using private hire vehicles to do the runs back and forth to the lab. In event that those private hire vehicles were not available, they were sometimes using ambulances and other MTUs. Now, you've also got to consider the depreciation of specialist fleet like ambulances and MTUs. It's completely unnecessary. And it's also taking those vehicles out of the supply chain. But, something that, thinking about green strategy, and I work in local government, so we've got carbon emission targets to meet as part of that strategy. We're running cars up and down the road all day long. And it also depends on the human element as well, which is traffic. So I think that there's massive potential for that. Looking way, way down the road, my dream is, thinking about organ transplant and what that could mean for speedy delivery of organs between a reception site as well and a hospital where, to date, those are either going in vehicles or by helicopter. And it throws all kinds of things into the mix where a reception site like a hospital is going to require, a helicopter, a pilot available, a landing pad, so on and so forth. So that's the future. I live in the future, and I think probably everybody in this call lives in the future, or you wouldn't be here, But we've got a lot of convincing to do to catch the rest of the world up. But I think that collaborations like this and coming together and having strength in numbers is probably more than half the battle. So I'll thank you very much for listening to us. And if you've got any questions, you can pop them in the chat. And we've also got our contact details here in the presentation if you want to get a hold of us outside of this forum. Thank you very much.
Fantastic, Deirdre. That was a brilliant introduction and an overview of what you've been up to. Brilliant. What we've got is we've got a couple of absolutely on the nose questions from Alex. And what I would suggest, instead of just me reading them out, Alex, can you unmute yourself and ask that question about the funding associated with some of these projects?
Sure. Hi, Paul. Hi, Deirdre. Yeah, I'll read hi there. I'll just read what's on the screen. But yeah, for a minute, you've talked about externally funded now, 24 of your 27 staff.
Yeah.
But does that mean that that you have money to spend on projects, or that you need to find ways of kind of creating revenue for that particular group? As in, you mentioned, for example, Horizon 2020. I'm trying to understand a little bit about whether you have money to spend if the right project comes along, or you need to find money.
Do you mean with subcontracted partners?
Well, you mentioned 25, 27 of you are kind of now kind of externally funded.
Yeah.
So therefore, we need, if you are a third party, you have to come to you with money to invest, or you have money yourselves to invest in projects?
It depends on the funding opportunities. So we will go into and approach funding opportunities generally with a consortium of partners.
Right, but if somebody comes to you, for example, just to follow up, and says, we would like to work with you, there's no money that you've got to invest yourselves. It's got to be part of funding that you can find elsewhere.
That we secure, that would be right, yeah.
Excellent.
But we would welcome an approach from you to go ahead and get involved in a project, Alex, I think something that we have is, where we sit as the iHub is that we are a local authority partner. So we have access to test sites and populations and so on and so forth.
Thanks, Deirdre.
Excellent. And Alex has very nicely put some details around the drop around bowel cancer in the chat. So that's very useful. That's adding a bit of data about the UK situation.
Yeah.
And I think Annalise has made a very, very good comment here about dangerous goods. And Annalise, do you want to take that a bit further?
Yes, I just introduced a comment because actually Deirdre I had the opportunity to discuss the same use case with a lab back in France, yeah. And the same story. Actually, the specimens are transported by mail, And I think it's one of the nice element about it is that one, it's one of the top cancers for men, so there is a serious issue. And then the second point is that actually it's not considered as dangerous goods, so that in terms of regulation, it's easier, especially on the drone side, because it's it doesn't qualify as dangerous goods. So just made this additional comment on the benefit of the use case.
Yeah. I also think the thing is, like, thinking from a socialization point of view, it's a huge leap. I mean, it depends on what age you are. I think for younger people, engaging with health services remotely and using technology is like second nature to them. But a lot of our very at-risk groups for cancer and so on and so forth, if you're going to go to all of that effort to engage them remotely, you have to be able to follow through 100%, because people will drop out of engagement and just say that doesn't work. So this was my point about and it's no disrespect to the Postal Service. They're brilliant. But, if you had to ask people to reprovide samples, for example, because they've gotten lost in the post, you may lose them forever out of the remote consultation wheel.
Excellent. I've just got one quick comment in the 2 minutes we've got left for your slot. And Deirdre, thank you for keeping perfectly on time. That was great.
It's not like me, Paul, as you know.
Exactly. I'm thinking about the opposite side, the people that are providing the technology. Is there a technology gap? Is there something that you need for some of these aircraft platforms that's not available at the moment for these various projects you're involved with? So
my stance is this. I think that we have the skill. I think that we have the skill, and I think we're approaching the point where my hill that I'm climbing is around the will to implement, because I think that there's, just on this call, I know that there's an incredible skill set that can deliver. And I also think it's a question of, is the technology that we have all singing, all dancing, all perfect? Probably not, but we also need to learn to walk before we run. So I would say that the skill set that we have within the UK and beyond and in the EU is perfectly suited for the current market needs, and will only improve as time goes on. Where we need to get is we need to get the will up to the skill level so that we can act. And I believe that I think COVID has provided that perfect storm. I spent time running around kind of talking. I've been talking about drones for years, and having, people who know me, because I'm quite an extrovert, kind of patting me on the head and saying, "Oh, Dee Dee, so funny. You and your, you and your ideas for running blood samples up and down the road by drones." I think they used to even call it Bloody Drones, my Bloody Drones project. But those same people have come around as a result of COVID to seeing the benefits, particularly when it comes to infection control and contactless delivery of anything to protected vulnerable populations, i.e. residential care homes.
I think you're preaching to the converted here, but we've got to get the good news out to the rest of the world.
That's it.
That was fantastic. And again, bang on time with the questions. So,
brilliant.
So Hammad, are you out there? I've got a hands up that I've just seen from somewhere. So where's that come from? Let's have a look, see. I can't. Who's got their hands up? I'm having trouble locating the hands up person.
It's Sheldon Cheskis.
Oh, hi, Sheldon.
Canada. Hi, how are you? Do I have time to make a comment?
Just a quick comment. Yeah, that would be great.
So I can tell you that, we've done a lot of this research already in Canada with respect to use of drones in an emergency response process. So the use of AED drones for out of hospital cardiac arrest. So my area of expertise is drone use, and much of the stuff that you're talking about, we've already done. I can tell you right now, it's not a technology issue. There's no question the drone technology is available to do much of what you're planning on doing. The issue will become regulatory, and I think that is where the real challenge lies. So we've done many test flights, BVLOS, in ranges of 10 to 12 kilometers for cardiac arrest. The trouble is going to be doing that in an emergency situation without the knowledge of what the final destination is. So all the testing that's been done around the world in this has allowed VVLOS flight, but to a known specified destination where the route has been previously checked out. The trouble with that, certainly for my use in an emergency medicine situation, is that's not real life. In real life, we don't know what the end route is. So the technology of drones is definitely there to be able to have sense and avoid, detect and avoid. We have all that technology. It'll be the regulatory bodies that prevent us, or at this point are making it much more difficult for the emergency medical use of drones. For the stuff that you're talking about, vaccine development, drugs like this, we've done much of this, and it's all doable because it's transport from point A to point B where there's a known route. So that, I think, is very doable. It's a great use. The other portion that I'm going to talk about, I'll just give a quick comment on, is the community. We did a lot of community work, community outreach in our communities where we worked with drones in terms of use of AEDs. And the most amazing things from the community is the communities love drones. Yes. They love technology. What was interesting is half of them said, well, what the hell am I doing with an AED? They had no idea how to use an AED. So it was interesting where you think the issue is the drone, the issue is actually the defibrillator. So that's why it's so important to get the buy-in from the community in terms of what you're doing. So I think this is phenomenal work. Much of it is, as I said, a lot of this has been being done in other areas of the world, but the key is going to be to get that final step will be regulatory, and it'll also be funding to be able to allow the drone companies to do their work without taking a huge bath and using all their R&D to be able to do some of the things that we're doing. So this is a great project, and happy to continue to listen, but I thought I'd give you some of those comments to give you a sense of what the challenges are moving forward.
Thank you so much. And can I ask you a question, Sheldon? Where are you from in Canada?
Toronto.
Best city in the world.
Yeah, that's great. Thank you. Thank you.
Best city in the world.
There seems to be a Toronto mafia going on here. That's fantastic. We have been a little bit naughty. We've overrun, but I thought those comments were superbly valuable, and of course now the chat's gone electric, which is very good. However, we have got Hammad here, who's been waiting very patiently, who wants to tell us about Apian. So, are you there? Yeah.
And I don't know if you guys realize, but we are in the presence of someone extremely sophisticated and esteemed, and that is Patrick from We Robotics, who just commented in the chat. He is an inspiration to myself and Chris, who's on the call as well, my co-founder. He's done monumental work in getting drones to be used in the developing world, particularly in a grassroots fashion. And I follow his work and his blogs closely, and I'm a big fan. I just want to say, Patrick, and you're an inspiration to the work that we do, and would love to actually chat with you later about some work that I'm doing at LSE right now. So yes, Chris and I, if Chris can say hi, if he can pop up and I think appear suddenly on the screen. We're the co-founders of Apian, and we are, in one line, we are a healthcare drone company. We are the interface between the medical and drone industries. So the problem that we identified, so by background, Chris and I are doctors in training. We are NHS clinical entrepreneurs, which means we're on a specific program which was launched by the NHS to support innovations from within the NHS to be applied within the NHS. We're also innovation fellows at Mid and South Essex NHS Trust, and have been very fortunate to be funded to do a number of projects which we'll go over. But the problem very much started when Chris and I were on one of our clinical rotations at Newham Hospital. We went into one of the laboratories, and to our surprise, the laboratory technician or the manager there said, "What on earth are you doing in here behind these doors? We never get medics behind, to come through." And we wanted to understand what their problems were, to figure out how we could help them from our perspective, using drones. And she came out with a torrent of problems, and A, B, C, D, E, and then quite literally implored us to go and help and talk to our consultants and to the funders that we were talking to try and solve a solution. But the problems we have identified are that healthcare logistics are just frankly in a chronic condition. And the symptoms are that, you know, air pollution is really big. The way, you know, it's not just the care or the quality of care that we deliver that's important. As doctors, we recognize that the way in which we deliver that care is also extremely important. You know, we always talk about being holistic in medicine, and it really doesn't make sense to me, particularly when I was learning, you know, at medical school, about how we need to be holistic in the way we treat our patients, but then the way in which we actually deploy that treatment is utterly there's no joined up approach. And so you can see that quite a stark fact that the air pollution air pollution by the NHS accounts for 5% of all UK road transport emissions. So it's quite significant. Slow laboratory turnaround times cost lives, and actually we've been working with a number of pathology partners now, one including Synab, which is Europe's leading pathology provider, diagnostics provider, and they said that although speed is an issue, it's actually not necessarily always the most prominent issue. Sometimes the most prominent issue is the ability to transport samples in a regular fashion throughout the entire day, such that you don't swamp the laboratory in one go at the end of the day because you've suddenly got a bulk load of 1,000 samples arriving, which immediately saturates all the machines in the laboratory, bringing it up to its capacity, and therefore you're immediately causing delays. So the idea here is that it's not necessarily about speed. Speed is important, absolutely, in many situations like pre-hospital care, absolutely. But in laboratories, speed is important, but so is the way in which we transport it. So doing it in a smarter fashion. And then actually we realize it's not just how we deliver it in a smarter fashion, it's about the ability for the laboratory to know exactly what's arriving, when it's arriving, and what priority those samples are, what's in the box. So at the moment, the NHS does unfortunately have a bit of a blind eye in terms of what is, it doesn't have, we're at Barts, we use CitySprint, we use EMIS, and we use all of these different technologies. And we spoke to our laboratory guys and they said, we have absolutely no idea when this sample is going to arrive. It's in the van. We know it's in the van. We don't know when it's going to arrive. We don't know how many samples are arriving. We don't know what those samples are. We don't know what the priority is. So all of this tells you that if you want medicine to be efficient, you need to actually provide valuable intelligence on what is being transported so that laboratories can plan better. And then moving on swiftly, we all know that unreliable deliveries mean that you have to have things on site because you can't transport it from a centralized hub. And therefore you have generally a lot of overstocking, a lot of duplication of services, and a lot of wastage of money. And so the treatment, we believe, is on-demand delivery of faster, smarter, cleaner healthcare using drones. And we're using VTOL drones that are manufactured, that are tailored by our partners, Skylift. We are, just to point out, we are drone agnostic. We are a healthcare company. We will work with any drone operator that has the right solution to the right medical need that we have identified. So we are drone agnostic. And so what that means is, as the interface between the two industries, we have a really good ability to work with multiple different partners and help the NHS leverage multiple different technologies rather than being limited just to one solution. Oh, you can only use our app if you use our drone. It's not like that, because we're coming at this from the medical perspective. We want the best solution to be used for the best situation. And we all know what the benefits are for medical deliveries, but I would say that one thing that we haven't talked about really is the way in which logistics can be revolutionized. It's the way in which just-in-time delivery can create new models of delivery within the NHS. So as trusts, as you may know, a lot of NHS colleagues on the call, trusts are extremely siloed. You don't generally have things moving from trust to trust. You do in specific circumstances. You get a specialized hematology sample being moved from Essex to Barts because Barts is a hematology center. But very rarely do you get normal bulk workload being moved between trusts. And as we get integrated care systems coming to life in the UK, what we find is that we actually do want, there's a drive from central government and from within the NHS to have shared workloads, so that potentially in the future drones can play a part in moving samples from one trust to another if one trust is having a bit of difficulty, moving, sharing equipment, sharing medicines, high value medications so they don't go to waste, centralizing things. All of these new forms of logistics have not been yet explored to their fullest extent, and that's primarily because we don't actually have this up and running yet. So of course we can't experiment just yet, but they are very much at the forefront of our minds, and we'll go over some of the work that we're doing, and we all know what kind of things we can send. So yes, we are the API between the healthcare and drone industry, and these are the sorts of things that we're working on right now. On the bottom left, you'll see here that we are developing an app that will enable healthcare staff, laboratory technicians, warehouse managers, clinicians, nurses, stock managers to securely order, track and build drone deliveries. And that platform will enable not only then to simply just see what's going on and move things from A to B, but then you utilize the data that comes as a result of that to better manage the inventory and for forecasting, so that you can preemptively act upon the data that you're receiving. So if you know that there's been a spike in the surge of a specific type of sample, then you know you can share that information with the trust and then can take action on that information more readily. We aren't just a software, we're also physical. We're building drone pads in partnership with some companies like so I know that there's someone on the call right now, Dennis Majo from we're working with on an Osprey project to work out how we can. So Motion Robotics specializes in creating automated drone pads that can enable drones to, without the need of human intervention, to offload and load drones. And the Osprey project that we have going on with Dennis is particularly fantastic because we have real life use cases to deploy that in Southampton, as well as our partnership with VersaPack to develop a tailored medical drone container with sensor technology on board. We're also working on the research best practice and guidelines because we can't get enough of that within the NHS. And I'll talk about the NHS Air Grid in a moment because it ties into one of the later slides. But if Chris can talk about the traction, that'll be great.
Yeah, I'm sure most of the people on this call are involved in some sort of amazing projects, and I think it's just worth bearing in mind that we are just very, very lucky to have all of you guys working towards and making this happen. And a lot of this is all about driven on the basis of COVID, and I think there's a shared kind of point of view or from everybody trying to help out as they can, and it's just so great to see changes happening so quickly. But yeah, so we've been very fortunate to be funded by ESA and UKSA, and as well as some UKRI grants with 2 million so far, as it states on the slides. And these are very much funded projects that we have going on. Just to quickly briefly, the project we had going on at Essex managed to reach about 109 million people, and some amazing people around in Switzerland have reached out to us as well. And my girlfriend's mom is an ophthalmology surgeon in Geneva, and she managed to hear us on the news somehow. So we were very, very fortunate to have such a wide reach. And this is a basic video of,
yeah, I'll skip this. We don't need
you can
it.
skip it. Yeah, so this is really a summary slide of kind of some of the amazing, wonderful partners that we have going on. It's just the tip of the iceberg, really. And I think most notably working kind of really with the logistics provider, Unipilot Logistics, which has the supply chain contract with the NHS board right now. So working with the amazing partners of Skylift and Skyports as well in the UK, whereby they are really just changing, developing the best drones that one could possibly make in accordance with the relevant regulations that we all love. And VersaPack, as Hammad mentioned, is really talking about making the standardized container to try and be UN 373 compliant, for example, but also people amazing in Southampton and with Tom Sherratt and Andy Oakley and Dennis down there. We're very fortunate to be working with them as well. And our homegrown is the South Essex, which is here in 2020. And this is kind of just a brief rough map of some of the aviation nerds. I'm sure you guys will know all about kind of air class space classifications. And you can see Broomfield, Bowson Hospital, and also Pathology First, which is the joint venture between SynLab and the NHS Trust there. And the aim really there is to try and deliver the COVID samples between the hospitals, because normally right now they all centralize it in Pathology First, and there's only one A road that connects it, and about often the times not there is a car crash on that A road, and there's simply no way of getting it across. And we believe that this is the first place to do it because we were born from there, and the direct innovation is there as well, but also because in the semi-urban environments where people live too.
Yeah, and just to touch on this, that we are just one step away from receiving BVLOS permission. We are currently working with Southend Airport to do some safety work before the CA can then approve the BVLOS flights. We are very close to flying it. Hopefully we can before the end of the year. one of the most exciting projects, and this comes into what Sheldon you mentioned about regulations, is you're absolutely right. Regulation is what's stopping this, nothing else. What we're doing here in Manchester is that we're not using a TDA. We're not using a temporary danger area that blocks off a section of airspace and is annoying for other general aviation users and is a lengthy process, and we all know is not fit for purpose. Here, what we're doing is we're flying in controlled airspace, in Manchester Airport's controlled airspace. And what that means is that we don't need a TDA. It means that we can fly as long as we agree with procedures that are agreed by the airport, by NATS, and by the Civil Aviation Authority. It means we can then fly, actually, technically, then at any point to, at any time to any location. So what this presents with is that we are then going to be hopefully then leveraging the learnings that we have in Manchester, the use case being that here you have the Lighthouse Laboratory, which processes over 700,000 COVID samples a day from nationwide location samples are running in as well as local. We're focusing on just the local ones because there's 19 test sites that fall within the CTR of Manchester Airport, and we're going to be hopefully flying those samples from those sites to the laboratory in a regular and timely fashion. But what we would like to do is take the learnings from this and exploit it into other areas which do obviously have much more dense populations and are within controlled traffic regions like London. And then in the Isle of Wight, as Chris mentioned, we're going to be hopefully flying chemotherapy from Queen Alexandra Hospital in Portsmouth over the Solent to the Isle of Wight, St Mary's Hospital. And we're working with some fantastic partners, Tom Cherrett in particular, who's leading the work in the Transport Mobility Zone, which is the government-funded project over there, has already done some work with wind racers. And you're absolutely right, Deirdre, that vaccines are going to be transported by drones. Wind racers are going to be doing that in the Isles of Scilly. So it's very much something that is real, happening right now. It's going to be happening. The use case here is that right now you have a ferry. Well, you need to first have a taxi that goes from Queen Alexandra Hospital to the edge. A ferry then takes it over, and then another taxi takes it over. That's in total a 3 to 4 hour journey. Sometimes, ferries are delayed. Sometimes schedules are unpredictable. Weather, sometimes they're down. And because a lot of chemotherapy do have a half-life and they're extremely expensive, what that means is the last thing you want is a £15,000 bag of chemotherapy to go down the drain, because that, my friends, that is worth 500, £30 delivery fees. So while we think about delivery fees as being the business model in the drone industry, very much pioneered by Zipline, actually it's a savings that can be that need to be economically brought to life so that we can justify why drones are being used, especially given that they have a high capital cost. And the work that Patrick is doing over in developing countries is particularly important. It's the work that I'm doing at the LSE in trying to economically evaluate the impact that drones can have on saving a mother's life so that they don't bleed out. Because rather than focusing on what's the benefit of getting the drone there, getting the blood there via drone instead of motorbike, what's the cost? Actually, it's the fact that I'm saving a human's life. What's the economic impact of that? So we've got to kind of step out also sometimes out of a comfort zone as drone nerds and as medics, and realize the larger impact that this has on society and push that agenda forward, because that's how politicians speak, and something that I've noticed in taking my year out at LSE. This is just to show that there are, of course, other areas in the UK that are much more practical in terms of their obvious use case in being very far away from centralised locations. But our holy grail is London, and we are working with SynLab, who have won a tender contract to provide pathology services for St Thomas and Guy's, and we're hoping that in just under 3 years' time to be flying in London, flying samples between those two hospitals. It's ambitious. A lot of people thinking, you guys are crazy. Yeah, but we think that that's the way you push the industry forward. It's through innovation. There's no point in doing something again and again that's already been repeated. We think that we want to really get the CAA to take them on a journey and realize, actually, come on, if we really want to unlock the benefits of drones, it's got to be in locations where it's really going to bring impact. And that's in the very rural locations, very isolated locations, and in the most urban of locations also, where traffic is a big, and air pollution is a big problem. And the idea is, of course, that we would build a network of hospitals. This is taken from the Nesta Flying High report, which many of you will be aware of. And the idea would be to then go international, and we're working with some partners, HR Wallingford, which is an industrial water company, and the Pasteur Institute, Louis Pasteur Institute in Senegal, to hopefully deliver rapid diagnostic test kits for dengue fever and malaria in Senegal and Tanzania. So there's very much our thought process is that we're going to build this in a safe regulatory environment. Yes, it's a strict environment, but at least we know it's safe. We know the processes, we know how to integrate into all the different systems, how the tendering processes work, etc. And then we want to then export that over internationally, not only to the developing world, but of course to other developed worlds as well. Our business model, which everyone likes to talk about, is that quite simply that drones do provide a economic value, a return on investment in select circumstances where it's extraordinarily expensive to get something from A to B if you're in an extremely isolated region. You know, Isle of Wight is a good example, but really there's not many of those locations around the world. Where you're going to get your revenue is coming from having a network of air corridors, even if you are flying beyond visual line of sight in an unsegregated airspace which you have to detect and avoid, you're still going to have air corridors in the sky, which are kind of like where you fly, because you're not going to go willy-nilly everywhere every time you fly something from A to B. You're going to use generally one kind of select airspace route. And that network that is built out when you're connecting different trusts, different hospitals, care homes, GPs, etc., pharmacies, all of these together, once you can leverage that network, that's when you can actually create a lot of value. And that's where the business model, we believe, lies. And as the NHS can start to consolidate its savings by consolidating warehouses, equipment, medicines, etc., and improving its purchasing power as a result, because you have the ability to do just-in-time delivery and consolidation, that's again where we think we can have a lot of savings. And we've been speaking to some medical equipment manufacturers who are very much willing to engage in this, because they have a lot of stock tied up on NHS shelves, which simply go out of, they expire, and that's a lost capital to them. And workload sharing, of course, as I mentioned before. And just briefly, the team, Chris and I, yes, we are just the founders, but actually we have Alex on board as well, who's a serial entrepreneur. He's an NHS clinical entrepreneur mentor. That's how we met him. And he's just joined us full-time today, in fact, but has been working with us for the past 12 months on our projects. We're very fortunate that we've also hired 4 more individuals with another 2 in the pipeline. So just from an Apian's point of view, we are growing. We see that this industry is growing, and we would love to work with many people here in the UK and internationally. And I'm very grateful to Paul for you bringing such a holistic range of people onto this call. And yeah, fire away any questions, and happy to provide as much detail as possible.
Hammad and Chris, that was absolutely fantastic. Just like Deirdre, the meeting chat is exploded in lots of connections and data and links, which is really good. I'm probably going to go back to front with the questions so I can sort of tick them off. Here we go. So I've got Alex here. How would you rate the PwC study with their 20% savings and sensitivity analysis?
That's a really tough question, because I don't know what data sources they used. I don't know the background to what inputs they had in their health economics or economic analysis, so I won't be able to comment. But I know we all like to talk about how PwC has given us lots of nice statistics for us to put in our funding applications. So I'm not gonna berate them either.
It sounds like you've used them very well, which is good. Deirdre's got a good question. What would you say that siloed working in the health and social care system is something realistically that can be overcome? So can we overcome this sort of silo working? How would we break down these barriers?
That's a pretty good question, actually.
Yeah.
I think oftentimes we often forget the psychosocial behind I think clinicians in general, the kind of behavioral change model whereby it's not very necessarily a individual person change, but it's a systematic change within the culture from the healthcare setting. I think that's really key. And I think oftentimes we look at quality improvement of these quality improvement include patient experience, first of all, safety, but also effectiveness of a treatment. And in any case, anything we try to do, we should be aiming towards that. And so I think a lot of it is cultural change and being empowering the patients, but also clinicians and the wider community themselves will be must be suited. And I'm so many people on this call, I'm just so inspired by a lot of people who are actually doing these work of community engagement and trying to get the people on board. I think that's where the change needs to happen. And as soon as I have those people on board, I think making change is a lot easier, and people would actually understand what the reasoning behind it and try to empower them locally, but also nationally as well.
And actually, as you mentioned yourself, Deirdre, COVID has forced trust to work in a different way, and they've had to collaborate. You know, so in Mid and South Essex, for example, we know that they've been providing PPE to not just their own local hospitals, but to other people, other care homes, which they normally wouldn't do because it's just not part of their SLA, it's not part of their business model, it's not how they operate. So I think COVID has given us an opportunity to work out actually there are better ways of working which are less siloed. And actually there's something else also really poignant that we've noticed, Chris and I especially, is that the younger generation is, around our age, I would say, and even younger than us. You will be surprised to see how many people, even younger than us, are so up in arms about changing and revolutionizing the way health systems work. They want to smash down barriers. They want to make things work more efficiently. They are sick and tired of hearing about problems, and we just do this because it's always the way it's been done. And, I've never questioned why it's been done. Actually, no, the younger generations are really, really against this kind of way of thinking. And I think that this is only good because it means as we go forward into the future, into the next 10, 15 years, as we have the influx of those people becoming, healthcare workers, that's only going to make the environment for innovation much more welcoming. Back in the day, if a junior doctor said that they had an innovation, they would be laughed out of the room by their dean, the medical education dean, and they would be told to quite literally pee off. And if they weren't, and this is anecdotal evidence, friends of ours who are in the years above in training, they were told that if you're not serious about doing your medical work, you can get out. You can leave the dean, the medical education, leave my office. And now actually it's more, you've realized that those trusts that do have really dedicated innovation departments are the ones that are now excelling in their ability to provide healthcare, like Mid and South Essex. So yes, the times are changing as well. So I do think, yes, it's positive. We do that siloed mechanisms will be broken down.
Can I just make a quick comment, Paul? I promise.
Please do.
First, I just want to say, I think incredible presentation, brilliant work, amazing. Please connect with us in Oxfordshire. Brilliant. I'm just blown away. I think my big fear right now, and I appreciate everything that you've said about, there's younger people in the NHS that are all up for innovation. Like, hey, us oldies are up for it too, But I think what I worry about is that, so what you're doing is so incredible. It should just be being done. It should just be automatically replicated everywhere. And that's my frustration, is that I think that what can stand in the way sometimes is, kind of decision makers rule the world in any big institution, whether it's the NHS, whether it's local government, whatever. And so how can we build on the opportunity of the last year and push this stuff forwards? Because my big fear is that, we all come out of the house and we just go back to how it was, and
yeah, no, it's a really good question. And actually we were talking, Paul and Dennis, who are on this call, and Tom Chair, we're working in Southampton, and we actually had a call this morning where we discussed quite literally this: is how do we get people in the CAA and in the regulatory authorities to realize actually that there is a need for this, and the NHS is vocal and wants to talk about this, but because they don't know how the CAA works, they don't know how to tell the CAA, hey, we'd love to actually have drones flying around. So the agreement came together that the way we would work around that is for more people from within the NHS, more clinicians, more academics to actually write letters of support for projects, so that the CAA and other people can realize actually, this project has a lot of support coming from within the community. This is not something that's just one person doing something because they've got a bit of money. Actually, there's a need here. I think the medical community, the academic community need to work together almost much more collaboratively as one unified voice in that sense, to lobby the regulatory authorities to make them realize, nah, this is actually a real deal.
But you see, because my thing is that what I always say, and it's why I started in my presentation saying it's very boots on the ground, my view, so I think there can be, when you work in the innovation space, there's like almost a disconnect sometimes between the space that we're working in and the real operational world. And what I'm interested in doing is bridging that gap, and I don't know how. I mean, obviously you've had some success in Southampton. We've had some success in Oxfordshire, but how do we keep going? How do we get the decision makers on our side? That's a big question.
Big question.
I think Alex makes a very good point in the chat, looking at risks of lives versus risks of aviation, and getting that balance right is important. I just want to thank everybody. This is fantastic. I've got a couple of slides, but we've actually run out of time. But I didn't want to curtail this lovely conversation. So what I will do, and basically I've already circulated that slide to everybody, is just to get some feedback, and I can do that within an email. I think the good news is that we've got our next two speakers sorted out. We've got Sheldon and Patrick. I kind of politely twisted their arms, and Sheldon volunteered me before I could finish my comment, which is good. I would love the conversation to continue, but I do understand we're all extremely busy. And this is one of the only meetings I've been to where the numbers have increased as the meeting has continued. So that's a good sign. But I'm seeing now people are drifting off because I guess they've got other things going on. So I'll circulate my little feedback slide and ask you to comment on that. I think format's important to consider. How we store this information, I think the video has been absolutely brilliant, and I'm going to pass it on to you, and I would encourage you to disseminate that within your own networks. I think timing's interesting. I'm not going to ask for any comments from you now. I'll wait for the feedback, but we've got many colleagues on the west coast of America, and it's a bit difficult for them, so it could be a later on in the afternoon perhaps, but I'll let you feedback on that. And also, I think Alex wanted things on the hour because most appointments are on the hour, and of course I've done it on the half hour. So there we go. But just thank you very much, Deirdre and Hammad and Chris, and all the lovely comments and things. What I'm going to have to do now is replay the video because I was trying to keep up with the chat, and that was exciting as well. And the presentations were brilliant, but I'm an old bloke now, so it was hard to keep up with both things, which is good. And my last comment, I'm very pleased that Essex is leading the way in drone research because, of course, all my family came from Newham around there. I didn't, but my grandparents did. And lastly, I love the term drone nerd. I think I'm going to pinch that as well.
Oh, we're drone nerds and we're proud. We tell everyone.
That's good. So I'm going to bring this meeting to a close because we're 3 minutes over. I'm going to send you that slide and I wait your feedback. And once again, just many thanks to the presenters and all of you for joining in the chat and the feedback in the chat. I've got millions of thumbs up, hearts, everything. It's very good. Thank you very much.
Thank you.
So I'm going
now. Thank you so much, Paul. Thanks, everybody.
Thanks so much.
This is brilliant.
Lovely to see you.
Thank you. Have a great weekend.
Cheers. Thanks.
Bye.